Good morning, everyone, and welcome to today's webinar on Ovarian Reserve Assessment featuring Dr. Sandy Lee from Boston IVF's downtown Boston and Stoneham Centers. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Additionally, we encourage you to submit questions to Dr. Sandy Lee using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer section at the end of today's presentation. Now, I would like to introduce you to today's speaker. Dr. Sandy Lee is a reproductive endocrinologist at Boston IVF. Dr. Lee graduated from Brandeis University with a double major in biology and biochemistry before earning a master's degree in medical science from Boston University. She earned her medical degree at Drexel University College of Medicine. Dr. Lee completed her residency in obstetrics and gynecology at St. Joseph Mercy Hospital and then joined the faculty at the University of California, Los Angeles, UCLA, where she saw OBGYN patients and conducted research in endocrinology as part of the STAR program. Dr. Lee completed her fellowship in reproductive endocrinology and infertility at Duke University. She then served as a reproductive endocrinologist and infertility specialist at Shady Grove Fertility in Maryland, where she was director of the Chinese patient program. Dr. Lee was born in China and moved to Brookline, Massachusetts during high school. She is bilingual in Chinese, Mandarin, and English. And Dr. Lee is excited to be back in Massachusetts, and she specializes in all aspects of fertility care. Now I'm going to pass it over to Dr. Lee.
Hi, everyone. Thank you, everyone, for taking the time to join me today. So today I'm going to talk about ovarian reserve, something that I think we're all familiar with. My slide is working. Yeah. So today we'll talk about what is ovarian reserve, how to assess it. We're then going to go over the tests available to assess for ovarian reserve and also how we can use them in our fertility practice. So what is ovarian reserve? So really, quite simply put, it is the number of oocytes left in the ovary, the quantity, not the quality. So the quality, which is the potential of a fertilized egg to result in live-born infants, is the result we all care about in the end. The quantity is a part of how likely that is to happen, but in theory, you really just need one. So let's look into ovarian reserve a little bit more. How many follicles do you start with? This has been examined in many studies, and one of the studies is like this one by Hansen and his colleagues. So before we get into the study, just as a reminder, we start out with these non-growing follicles, or NGFs, and these are the reserve. And once theca interna differentiates into the pre-antral follicles, it becomes gonadotropin responsive, and the follicle is considered to have entered the growth phase. So antral follicles are a more advanced stage of follicular development. A cohort of antral follicles is recruited in the early follicular phase in response to the elevation in gonadotropin levels. And then in most cycles, a single follicle will ovulate, but the majority of the cohort will undergo atresia. Follicular atresia as well as ovulation, they together and slowly depletes the ovarian reserve over time until menopause. So at the time of puberty, estimated ovarian reserve is about 500,000. And then during a woman's reproductive period, about 400 oocytes are ovulated. By menopause, overall ovarian reserve declines to less than 1,000 oocytes. So Hansen looked at ovarian tissue from about 120 patients over a range of ages who are undergoing elective unilateral or bilateral oophorectomy to come up with an idea of how the number of NGFs change over time. So one can see that it does, there's an age-related decline with time. And furthermore, they found that NGF count decay was best modeled by a simple power function, and that implies follicle decay faster with increased age. So the power model suggests that the decay of NGFs constantly accelerates rather than suddenly increase at 38 years old. I think what we're used to seeing is kind of a flatter curve, at the beginning prior to kind of mid-30s, 36, 37, and then we see a more steep curve, after 37, 38. But some of the newer studies has shown that's actually not the case, and we're actually seeing kind of an age-related decline, and that accelerates with aging. So the mechanism for this increasing rate of decay with age is not clear, but one thought is that increasing concentrations of FSH as observed in the older reproductive age women could contribute to the acceleration of follicles leaving the resting phase to enter the growth phase. So, age obviously is a big factor in ovarian reserve. There are other factors, shown here. They are genetics, medical interventions, environmental factors, autoimmune disease, chemotherapy. They can all play a role. And these are things that we obtain in our patient's history. And of course, in addition to history, we have several diagnostic tests we can use to try to assess a patient's ovarian reserve. So let's review some of the major tests used for assessing ovarian reserve now. Tests of ovarian reserve can be, either biochemical assays or it can be ultrasound. And biochemical tests can be further divided into cycle-dependent, cycle-independent, or proactive testing. So of the biochemical tests, the cycle-dependent ones, which are the ones we're most familiar with, and these are the early follicular phase hormone levels. These are inhibin B, FSH, E2, and then the cycle-independent one would be anti-Müllerian hormone, or AMH. So the first one I will talk about is cycle-dependent tests, and this is FSH and E2. So the pituitary gland secretes FSH, we all know that, and the FSH stimulates follicular growth, elevated E2 concentrations, and we know that higher early follicular FSH usually suggests a more advanced diminished ovarian reserve. Separately, an early E2 rise, and that's usually due to advanced premature follicular recruitment, is also a characteristic of reproductive aging and poor ovarian reserve. So high E2 level, they inhibit pituitary FSH production, can lower an otherwise elevated basal FSH into the normal range. So if you're just measuring that FSH alone, it may appear normal in some of these patients with, early elevated E2 levels. So it is very important to measure both of them to help avoid getting that false negative FSH testing. So overall, elevated basal FSH or elevated basal E2 with normal basal FSH level, they can both be a sign of diminished ovarian reserve. I also want to talk about another test, which we all, hear about. It's been around for a long time, and this is the Clomid challenge test, the clomiphene citrate challenge test. So in this test, we measure serum FSH on day 3 and then again on day 10 after Clomid administration. And Clomid is a weak estrogen agonist antagonist. They bind to estrogen receptors in the hypothalamus that results in the release of FSH and LH from the pituitary gonadotropes, and elevated FSH after clomiphene, which suggests diminished ovarian reserve. So in women with diminished ovarian reserve, smaller follicular cohorts that were recruited generates less inhibin B and E2, and that results in a decreased negative feedback inhibition of FSH secretion and higher stimulated FSH concentration. So the use of Clomid challenge tests, they may increase sensitivity for detecting diminished ovarian reserve, but compared with baseline FSH and antral follicle counts, the clomiphene stimulated day 10 FSH is actually not superior to the other non-dynamic tests for predicting poor ovarian reserve or pregnancy after IVF. So right now, the position of ASRM is that this test really should no longer be used for this purpose. However, many insurance, they still use this. They still require this test, especially in women over the age of 40. And they're still using the results from the clomiphene challenge test as basis to deny, IVF treatment coverage in women with abnormal results. So AMH is our cycle-independent test, and AMH remains relatively consistent, stable, within and between menstrual cycles. It is more sensitive than FSH, and it tends to decline before we see the rise in FSH. Because it is produced by the granulosa cells of early follicles, it is a direct reflection of the number of early follicles. So you can see from here in this slide that at AMH level, it peaks with peak fertility, and then it starts to decline. And it also can be decreased in women using hormonal contraceptives. So usually when I have a patient that come in and they've been on birth control pills for a while, or they're on it now, I usually have them stop that, for a couple cycles and come back for testing. Ultrasound is also an indication of ovarian reserve. We know that ovarian volume itself, they do decline with age, but as there is great inter and intracycle variability and general lack of sensitivity, usually ovarian volume is not used to assess for ovarian reserve. On the other hand, antral follicle count is very good. It's a very good assessment of ovarian reserve. Antral follicles are those that measure somewhere between 2 to 10 millimeters in diameter in the greatest plane across the ovary. It is the number of antral follicles in both ovaries observed by transvaginal ultrasound during the early follicular phase. It has low intercycle variability and high inter-observer reliability in experienced centers. So of the assays that we have reviewed, AMH levels appear to be a more sensitive marker of ovarian reserve compared with early follicular phase hormone levels. AMH tends to decline before FSH elevation. High FSH is a specific marker for diminished ovarian reserve, but fails to detect a more subtle decline in ovarian reserve. AMH and AFC have both been shown in many studies to be equivalent, although AMH is more simple to administer because it is just a blood test. So we have been talking now about tests of ovarian reserve, but once you have assessed the ovarian reserve, what does it actually mean? One might imagine that ovarian reserve should predict reproductive potential, but this has not been borne out in studies so far. Many studies have been conducted to assess the value of markers of ovarian reserve as markers of current reproductive potential. And in these studies, it was found that ovarian reserve markers were actually poor predictors of reproductive potential as measured by fecundability, cumulative probability of pregnancy, or incidence of infertility. So in women with unproven fertility, these markers are not as helpful. What about women with infertility? Yeah. So although the data is limited, ovarian reserve testing is no more useful than age alone in predicting unassisted pregnancy in women with infertility. Adding this data to established pregnancy prediction models like the HONOTS do not change patient management, and very limited data suggests that AMH does not predict treatment success rate after ovarian stimulation. But how about in patients who are undergoing IVF? Is this helpful? So there are actually conflicting data for AMH as a prognostic measure for oocyte quality and clinical pregnancy. AMH is only weakly predictive of pregnancy at best. While clearly it is very important, there are many more variables. For example, women's age, the male factors, sperm quality, embryo development, stimulation protocols, procedure and laboratory techniques, they all play, very important roles in terms of clinical pregnancy. So usually we do multiple testing, right? We typically don't just check AMH, we check day 3 labs as well. So, what about combining these multiple tests? How useful are they? So also that does not seem to make them more helpful. Sometimes it's helpful, for us when we're doing simulations and looking at, ovarian response with different protocols, but sometimes these multiple testings can also lead to discordant results, and that can complicate the management and also confuse the patient further. So truly, what can these testings actually help us do? AMH and AFC, they can predict oocyte yield, as well as poor or excessive response to gonadotropin stimulation with many ART studies. Extremely low AMH values may be used to appropriately counsel women regarding suboptimal response and yield. However, because of the poor correlation to pregnancy outcomes, low AMH level really should not be used to refuse treatment. The other term that we may all hear about is ovarian reserve and ovarian versus ovarian response. So we know ovarian reserve is reflected by the discussed tests. They correlate with oocyte yield. Ovarian response, on the other hand, is defined by the actual oocyte yield after ovarian stimulation. So poor ovarian response is identified by a reduction in follicular response to maximum stimulation during IVF procedure, and that in turn results in reduced number of retrieved oocytes. The definition of poor ovarian response, this is usually defined by 2 out of 3 of the following criteria. One is women with advanced reproductive age, advanced maternal age greater than 40 years old, or other risk factors for poor ovarian response, a poor previous ovarian response in treatment cycles, or an abnormal ovarian reserve test. So poor ovarian response can also be defined as 2 episodes of poor ovarian response after maximum stimulation. That is sufficient just by itself in the absence of maternal age or abnormal ovarian reserve testing. So if good or poor ovarian response has been demonstrated recently, then additional ovarian reserve testing is really not necessary. So, what is the role of testing? So really the goal of ovarian reserve testing is to add prognostic information to the counseling and planning process to help couples choose among treatment options, because ovarian reserve tests test quantity, not quality of the remaining oocyte pool. These ovarian reserve tests are not infallible. They're not meant to be the sole criteria used to deny access to ART. However, I have to say this is used heavily in insurance. Clomid challenge test is one of those things that's being used. They have pretty strict cutoff. I've just had a couple of recent patients who failed the Clomid challenge test and they were denied IVF treatments. Same thing, the basal hormone levels, FSH levels, and is also used by insurance heavily across the board. Typically, an FSH level above 15 is usually what's used by insurance to deny IVF coverage as well. But as we see from here, decreased ovarian reserve does not necessarily equate with inability to conceive. So I thought it might be interesting to show a few cases to see kind of, what these ovarian reserve testing mean and what is the outcome when we see patients with, low or high ovarian reserve testing. Really, I think the key things to remember is they don't predict fertility. They do predict, egg yield. So this very first patient, this is a very interesting patient. Let me move this screen. So the very first patient, she is a 32-year-old G0. came to talk to me about fertility preservation. And the reason she's doing that is because she has a family history of her mom with premature menopause. You know, she's 32, she's single, she has no plans to have a family or have kids in the next 4 to 5 years. So her ovarian reserve testing showed, you know, of course, diminished ovarian reserve, as we can see, AMH of 0.5. So anything less than 1 is considered in the diminished ovarian reserve range. So her AMH is low, and then correspondingly, her FSH mildly elevated, E2 is normal, her antral follicle count is in that low normal range. So she underwent 1 round of ovarian stimulation, and we used a max dose protocol, and as you can see, she got 4 mature oocytes, which is not a very high yield. Now, very interestingly, her sister came to me after that. Her sister is a little bit older, you know, 34 years old, also a G0, also to talk about fertility preservation. So we end up having ovarian function testing, you know, very nicely demonstrate kind of the age-related decline, you know, 2 years older, her AMH level is slightly lower at 0.3, you know, FSH is at 5.1, which is the normal range, but if you look at her E2 is 217, is significantly elevated. Typically a basal, you know, day 3 E2, we would expect it to be, you know, below 70, 80, typically even lower than that. So she has an elevated E2, and that's what's giving us that false negative FSH level there. Antral follicle count of 7, which is low, consistent with her lower, you know, AMH. So the sister hasn't, she's just finished her testing. She hasn't gone through, you know, her treatment cycles yet. I would predict, you know, she may have even lower yield than her younger sister. Next case. So the third case, you know, similar age, 32-year-old G0. This is a patient who came to me with a history of polycystic ovarian syndrome, ovulatory dysfunction. Similar story, you know, she is a graduate student. She is not planning to, you know, to have a family, have kids, at least for another 5-6 years. So we see in PCO patients, they tend to have an elevated ovarian reserve, a high ovarian reserve, as demonstrated here by her AMH level of 9.9. She has normal FSH, normal E2, and look at her antral follicle counts, 37, tons of follicles. So she also underwent 1 round of ovarian stimulation. And with her, because of her, you know, high ovarian reserve, I used a very low dose, you know, ovarian stimulation protocol, and her yield is significantly higher, which is what I would expect with a higher ovarian reserve. And she had 25 eggs retrieved. So this is just, you know, to demonstrate that it is helpful, and we don't really know, you know, what these eggs are going to translate into in terms of embryo and pregnancy in the future. But as we can see very nicely, these are at the extremes of ovarian reserve. You know, the 2 sisters, very low reserve, and then the PCO patients with very high reserve. And, you know, as you can see, they have low and high numbers of eggs retrieved. And this is what we see in our practice, that this test is very helpful in terms of predicting oocyte yield. And it does help guide us in terms of kind of designing their treatment protocols for stimulation. This next patient, you know, what I wanted to show in the next 2 patients is that, you know, the ovarian reserve, not as predictive of pregnancy rate, you know, fertility potential. This is a 34-year-old G0 with primary infertility for about 2 years. Her ovarian reserve testing showed low ovarian reserve. You know, this is very similar to that first sister in case 1. AMH level of 0.5, FSH of 12, mildly elevated, E2 normal, antral follicle count kind of in that low normal range. So she underwent 1 round of IVF. She also got 5 oocytes, and 2 of them became embryos, and we did a single embryo transfer, and she had a normal pregnancy, beautiful baby, nice delivery. Very straightforward. I would say look at her age. She's 37. She's 34 on the kind of younger side of our infertility patient. Next patient, 40 years old, G0, primary infertility for 1 year. Her ovarian reserve testing showed very normal ovarian reserve testing, normal egg quantity, AMH level of 1.9, FSH normal, E2 normal, antral follicle count completely normal range. With her first round of IVF, we got 13 eggs, and out of those, 4 became embryos. Because of her age, her embryos underwent pre-implantation genetic testing for aneuploidy, and they all came back aneuploid. Okay, so at age 40, oocyte aneuploidy rate is actually fairly high. About 50% of eggs are affected with aneuploidy. So she actually did not have any transfer. So then we had a second round of IVF. In the second round, she had more eggs retrieved. As predicted by her normal ovarian reserve, she had 15 oocytes retrieved. Out of those, she got 5 embryos, and that also underwent PGTA testing, and she got 1 euploid embryo. So we transferred that euploid embryo, no pregnancy. So really, I think from these 2 cases, as you can see, the first one, despite having very low ovarian reserve, she had 2 embryos. She's younger, her egg quality is better, and she's able to conceive. The second patient, even though she has many more eggs retrieved, many more embryos even, that aneuploidy rate is very high, and after 2 cycles of IVF, still no pregnancy. So, ovarian reserve testing, what should we use it for, right? So really, it should not be used as a fertility test for women who are not infertile or who have untested fertility. It should not be used to just promote planned, egg freezing. This should be kind of based on women's reproductive plans and age, as with those 2 sisters, right? We're not doing the testing just to see if they have low reserve, but because they have a family history of premature menopause in the mom. So age is a much stronger predictor of reproductive success than ovarian reserve. Ovarian reserve testing should not be used to deny access to infertility treatment. Unfortunately, this is not true with insurance. It is being used to deny fertility treatments in many patients, many older patients. Ovarian reserve testing should be used to predict oocyte yield and assist us in evaluating ovarian responsiveness. And this information should be used as part of the data to counsel patient on their ART options.
Thank you so much, Dr. Lee. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Lee, our first question is, in someone with diminished ovarian reserve who is doing egg freezing, how do you counsel them about the number of eggs to freeze and how many rounds of treatment cycles to achieve adequate number of eggs?
Okay. Thank you. This is actually a question that comes up quite often when I see patients for the initial consults, especially in patients, going through fertility preservation. So really the recommended number of eggs to freeze is mainly based on age. As we all know, as we get older, egg quality does decline in addition to quantity. So usually in women 37 years old or younger, we recommend freezing about 20 eggs, and that would give someone an about 80% chance of 1 live birth, about 45 to 50% chance of 2 live births. Someone with diminished ovarian reserve, as you can see from the first sister and the first DOR patient, they are likely going to need multiple cycles to achieve that number. The first patient, she got 5 eggs with 1 cycle, and I would say about 10 to 20% of patients with low normal ovarian reserve or diminished ovarian reserve are going to need somewhere between 2 to 3 cycles to kind of achieve that kind of egg counts.
Thank you. The next question is, how often should the ovarian reserve testing be repeated?
Okay. Yep. In our patient population, in our infertility patient population, we do usually repeat the testing, every year. This helps guide us in terms of adjusting their treatment, protocol treatment, medication dosage. But I think in the general practice, I wouldn't recommend yearly testing unless you're doing a workup for infertility or people with irregular cycle or, someone with significant family history of, things like premature menopause, for you to take a look to see if they have a more accelerated decline, to help counsel whether they need to consider things like fertility preservation. Yeah, but I don't think it's something that needs to be repeated every year.
Thank you. The next question, do you prefer us to send patients with the testing already completed?
I would have to say it's helpful when we see patients with some testing so that we can counsel them a little bit, but I would say most patients will still need some additional testing. Typically, when you do a baseline ultrasound, it doesn't give us information on antral follicle count. So that's one of the tests we usually have patients repeat. And sometimes, patients will come and their testing results are, more than a year old. So in those cases, we end up repeating them anyway. So I think if it's something that can be easily done in your office or in your center, you can get an AMH. I would say leave the day 3 testings to us because we still have to do that antral follicle count, at early follicular phase. Yeah.
Okay, great. The next question is, are there ovarian reserve levels that you would not move forward with for treatment? So is there a level that you'd be like, I can't treat you?
Absolutely wouldn't treat. I would have to say no. Just to give you an example, I had a patient that her AMH level came back at 0.1. And then we also looked at her antral follicle count. Her antral follicle count showed, 7 follicles, which I feel, the AMH level, I would expect maybe I will see 1 follicle. If she has 1 follicle, AMH of 0.1, I would strongly cancel depending on her age and also previous treatment. Maybe she need to consider donor egg. However, when I see kind of adequate number of antral follicle counts, I do consider doing a cycle, especially in someone who is younger. So I don't just use that alone. In situations like that, one thing I do, sometimes I repeat it because there are different platforms for assessing AMH. Sometimes with one test from one lab is extremely low, and then the other one may be, fairly reasonable. I also, in those patients, I also do the antral follicle counts to look. Yeah, so usually I look at that day 3 testing together in those type of situations to help me make a decision. Yeah. But of course, if this is someone who is, say, 43 years old, AMH of 0.1, antral follicle count of 1, I will strongly counsel them to consider donor egg rather than doing an autologous IVF cycle.
Okay, our next question, can you talk about BMI cutoff for ART?
Okay, so at Boston IVF, our cutoff for IVF is 45, BMI of 45. It's not so much, it's more because of anesthesia risk. I don't use any BMI cutoffs as an absolute cutoff for not providing ART. I think a lot of it is just consideration for risks during retrieval. In those situations, we refer them to a hospital where they may have, they're in the in-hospital setting, or if there are issues, they'll be able to deal with that more adequately than in an outpatient center. But usually, no, I don't use BMI as a cutoff to deny ART.
Thank you. The next question, in sisters with diminished ovarian reserve and the mom with early menopause, would you check for Fragile X carrier state?
Absolutely, yeah. So in those sisters, I checked Fragile X for both of them. So that's one thing I would check. I usually will run, some a thyroid function to look for autoimmune causes. Sometimes they may also have, other autoimmune issues that may lead to, adrenal insufficiency as well. So I do check a anti-adrenal antibody as well. In addition to fragile eggs, I check a karyotype. I also do a full thyroid function panel, not just checking TSH, but also the antibodies, the thyroid antibodies as well.
Great. The next question is there a maximum age where you do not offer IVF? If yes, what age and why? And have you had patients in the mid-40s conceiving for their first pregnancy?
Yes, very good question. I have to say, I had a patient today who is turning 45 in 2 months and coming to me to talk about this. So yeah, in Boston IVF, our age cutoff for autologous IVF cycle is 40, women's 45th birthday. There are definitely some centers in the country that would do ovarian stimulation in older women. Truly what you're looking at is that when you look at a woman who is 45 years old, their live birth rate with IVF, a good stimulation cycle is less than 3%, very small chance of success, but it's not zero, right? And when you look at oocyte aneuploidy rate at age 45, it's going to be greater than 95%. So what we're concerned more is that they have extremely low, success rate, very high miscarriage rate at age 45 using their own eggs. Their miscarriage rate is going to be above 50, 60%, could be even higher than that. So then you have to think about, is it reasonable? Are we doing the right thing, kind of putting someone through ovarian stimulation, egg retrieval on these large doses of hormones for such a small chance of success, versus if they, if donor egg is acceptable to them, their pregnancy rate with donor egg, possibly inseminated by their partner's sperm, their pregnancy rate can achieve, reach about 50%, between 50 and 60% with, miscarriage rate only in the 10 to 15% range. So usually I talk to women about their options. Many times we do a cycle we call a closure cycle. Many of them kind of at the verge of that cutoff don't feel comfortable just moving right into donor egg. So as long as they're counseled, they understand the low chance and the high risk of miscarriage, we do support them a lot of times, through a closure cycle. I think it's more psychological than anything to provide closure for these women. And many of them do end up moving forward with donor egg.
Thank you. Our next question is it possible to check for ovarian reserve, do ovarian reserve testing in women with Mirena?
With ovarian mass?
No, sorry. Is it possible to check ovarian reserve in women with Mirena, the IUD?
With Mirena, absolutely. Yeah, very good question. So we actually, for women, we have many women coming to us for egg freezing and they have IUD in place. For Mirena IUD, they actually don't need to remove it. We can actually stim, do stimulation without taking the IUD out, and they do very well. Every once in a while, if they have very inconsistent ovarian function testing, between the AMH and the antral follicle counts or day 3 labs, I may have them remove the IUD and recheck, just, consider maybe, it's doing something, but most times the IUD can stay in place and they can go through their testing.
Okay, and I think this is our last question currently. If we do cryopreservation of eggs, so if you do egg freezing, can it change your chances of conceiving in the future?
No. So a lot of women ask me, when they come to me, they ask me, well, if I did 2 cycles of egg freezing, you took that many eggs out, is that gonna, lower my fertility or decrease my put me into menopause early? And the answer to that is no, because when you look at follicular recruitment, right, in a menstrual cycle, kind of around the start of your cycle, you actually recruit, multiple follicles, and truly, typically only one gets ovulated, and many of the follicles in that cohort undergo atresia. And with IVF and fertility preservation and ovarian stimulation, we kind of support you with the extra hormones. Those are the stimulatory hormones injections we give you, and that can stimulate and support the growth of some of these other follicles that may otherwise undergo atresia. So yeah, so the short answer to that is no, it doesn't. Some of those follicles are destined to be lost anyway, and doing a couple cycles of ovarian stimulation, in the grand scheme of things, it doesn't really decrease your overall reserve by that much. Just remember when we talked about the number of eggs that are actually ovulated is only about 400 to 500. And your reserve, I would say in your mid-30s, is probably around 200,000. Okay, so actually a very small number. Even if you freeze, 100 eggs, a very, very small number. Yeah, in that, looking at the overall reserve.
We actually have a follow-up question to the Marina question. If
Sure.
the woman is not menstruating on IUD, when do you check?
How do we check? Yeah, very, very good question. So we actually just have them come in for a random ultrasound. We'll do a random ultrasound. We'll check FSH, E2, LH, and we check the AMH level too. So that helps us kind of determine where they are in their cycle. And usually we start stimulation. We can start stimulation if their E2, FSH are low. Their hormone profiles looks like they're not in that ovulatory window. So we just have them do a random. Yeah.
Okay, and do you offer IVF to patients in their early perimenopausal period if they so desire?
Beyond age 45, we don't usually offer autologous IVF cycle. A woman can transfer, like for example, some of these women, they have, egg cryopreserved, they have embryos. We can transfer their embryo up to age 50, but we usually do not stim their ovaries, to retrieve eggs after age 45. It is sometimes we do make exceptions, for some people depending on their history, and that's usually kind of we have to present them in our board and go over it, and we have a vote. And depending on their history, sometimes we do allow people, when they're very close to that, to allow them for one cycle, but most times no.
That was our last question. Thank you so much, Dr. Lee, and thank you for everyone for attending today's webinar on Ovarian Reserve Assessment. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com, or my cell phone 978-302-2958. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Sandy Lee, thank you for joining us today and enjoy the rest of your day. Thank you, Dr. Lee.
Thank you, everyone.